Good evening, friends. Today, our guest speaker is Dr. Wendy Stock from Chicago, USA. She is going to lecture us on adult ALL advances in last 1 decade. This webinar is brought to you by Mumbai Hematology Group. It is supported by Pfizer and Nirvin Life Sciences, managed by Mice Ideas. I thank Mr. Safal Jadhav and team from Pfizer, Paresh and their team from Nirvin, Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Wendy Stock, all our discussants who are themselves eminent hemato-oncologists, you participants for sparing your Saturday evening. Just to remind you, tomorrow morning we have Dr. Martin Drelly, who is speaking to us on mantle cell lymphoma, a subject that he has been researching for the last 30 years. That will be at 11:30 a.m. Well, our discussants today is galaxy of virtually who is who from India. All of you know them and even our audience knows them. So I'm just speedily going to go over their names. We have Dr. Aditya Murli from Bangalore, Afaq from Srinagar, Aishwarya from Ahmedabad, Khurana from Surat, Mohite from Kolhapur, Dr. Chetan Damne from Mumbai, Deepankar Lucknow, Deepanjan Haldar Mumbai, Hari Menon Bangalore, Kishore Kumar Chennai, Lalit Mohan Jaipur, Manoj Unni Kochi, Neeraj Kochi, Prasantha Mangaluru, Rajani Priya Vishakhapatnam, Riya Nagpur, Sada Shivadu Hyderabad, Satish Kumar Bangalore, Dr. Verma Lucknow, Dr. Sharad Damodar Bangalore, Dr. Sonia Nityanand Lucknow, and Dr. Stalin Bala from Hyderabad. Thank you very much for joining us this evening and preparing your questions for our speaker. And it's my pleasure now to introduce Dr. Wendy Stock. We've had lectures on childhood ALL a couple of times, but of late we have not had any lecture on adult acute lymphoblastic leukemia, a field where so much has happened in the form of immunotherapy in the last 1 decade. She's from section of hematology oncology. Anjali Seth Nayak Professor in Leukemia, Director Leukemia Program, Professor of Medicine, Department of Medicine, University of Chicago. She is involved in clinical and lab efforts directed towards improving treatment for adult leukemia and MDS. She's focused on the development and conduct of novel therapeutic trials in these diseases, both at the institutional and national level. She's a co-leader of the University of Chicago Cancer Research Center's program in hematopoiesis and hematological malignancies. She's a core member of the Leukemia and Leukemia Correlative Sciences Committees in the Alliance and NCI-sponsored Clinical Trials Cooperative Group. She is co-chair of the NCI National Clinical Trial Network Leukemia Steering Committee. She recently led national trials for treatment of acute lymphoblastic leukemia in adults and the University of Chicago's efforts to develop innovative trials for patients with advanced ALL and AML, including novel trials of allogeneic stem cell transplantation. Her lab focuses on studies to determine the clinical significance of the molecular detection and monitoring of MRD status following treatment and is the national reference lab for several of these studies. She's also developing novel technology to measure tyrosine kinase activity in leukemic cells as a method for predicting response to treatment with novel targeted kinase inhibitors. Today, she's going to lecture on adult acute lymphoblastic leukemia advances in last 1 decade. Thank you so much, and over to our speaker.
Thank you so much for that very kind and generous introduction, Dr. Agarwal. I'll try to share my screen now. It's my pleasure to join you all this evening. It's early morning here in Chicago, and I say good morning to all of you and good evening to all of you at the same time. Can you see my screen?
Yes.
Okay, very good. So I've titled my talk, Taking the Next Leap Forward in ALL, and I'm going to be talking about the melding of the beauty of youth, our young adult programs, with the wisdom of age. and focusing a little bit at the end on our older adults with ALL. These are my disclosures. The objectives are to review the progress in the treatment of young adults and older adults with ALL, to evaluate new strategies to eradicate minimal residual disease, including some of the immune targeting approaches that Dr. Agarwal just mentioned. The thought of incorporating nelarabine into frontline for patients with T lymphoblastic leukemia, and some of the challenges that we face in adapting some of these pediatric regimens to older adults. And then really looking at what we're doing in older adults to try to overcome the obstacles of treating them with pediatric regimens and the path forward as we move into a very exciting, as Dr. Agarwal said, future. So this all started a number of years ago for me, where I made an interesting observation with colleagues that patients who were the same age, the youngest of our adult population, ages 16 to 20, had very different outcomes when they were treated on pediatric versus adult trials. The same group of patients, but you can see here from this slide, dramatically different outcomes based on whether you were treated by a pediatric cooperative group in the United States versus one of the adult cooperative group trials in the United States. And these results were validated many places around the world. So our efforts focused on trying to overcome these obstacles, first trying to understand what they were, and then trying to overcome them to allow better outcomes for our even youngest adults with acute lymphoblastic leukemia, where clearly other people were achieving much better outcomes. Well, what it turned out was that there are a variety of factors that influence those outcomes. But what we have learned over the last decade is that adoption of pediatric regimens, faithful adoption of pediatric regimens in young adults with ALL has improved survival. I'll show you that in a minute. And that includes the intensive use of asparaginase, vincristine, glucocorticoids, and very intensive intrathecal therapy. These regimens have proved to be feasible for younger adults with low treatment-related mortality, and toxicities were manageable, but they do increase with age, and that brings up some of the challenges that we're going to talk about later. However, these regimens have resulted in very major improvements in event-free survival and overall survival compared to historical controls, where our survival rates for our younger adults now approach greater than 70% in many places around the world. And these pediatric regimens have become a new standard of care, but as I previously just mentioned, there are biological limitations, obesity, and potentially changes with age. Oh, my slide seems to be frozen here. Let me see, there we go. This is one of the regimens that showed an improvement in outcome for younger adults, actually patients up to the age of 50, when a faithfully replicated pediatric regimen was used in these patients. This is from the Dana-Farber Cancer Consortium, Dan D'Angelo and colleagues, and it shows here a very robust 69% disease-free survival with good long follow-up, and you can see here a very nice plateau on the survival curve. The United States, for the most part, participated in this trial, which I had the honor of leading, 10403. It included patients ages 16 to 39 years, up to the age of 40, and was a pediatric regimen. What we did was we took the standard arm, the control arm of a very successful pediatric regimen, COG regimen AALL 0232, and we replicated it in our young adult population. And here's the regimen shown here on this slide. It's a typical BFM type regimen with intensive blocks of chemotherapy, very heavy on the asparaginase, very heavy on the intrathecal methotrexate, prolonged maintenance therapy. And in this regimen, patients with TALL did receive prophylactic cranial irradiation at the end of the 4th block of treatment before going on to interim maintenance. Long-term maintenance. With that, the results are shown here. They were published a couple of years ago now. You could see the historical perspective shown on the left, which is what's displaying now, and the results of the 10403 trial, where in fact, the hope of replicating those results in the pediatric group were achieved with an overall survival of 73%. We also recently asked the question of whether there was a potential benefit to transplant in first remission, because that's a question that most of us face when we're meeting a patient with ALL. Do they need an allogeneic transplant in first complete remission? And while this is not a perfect study, since it's not randomized and it's a prospective study compared to registry data, it does, I think, give very important insights into the outcomes of patients, young adult population who undergo allotransplant in first complete remission. And what was done by Matt Wiedewold and colleagues was to compare the 10403 regimen, which I just showed you, which included 295 patients, to a contemporary cohort of patients in the bone marrow transplant registry who underwent allogeneic transplant in first complete remission. And in multivariable analysis, the allogeneic transplant was inferior to the 10403 for both overall and disease-free survival, and of course, non-relapse mortality. And largely this was due to the fact that allogeneic transplant, as we all know, is associated with higher non-relapse mortality, but actually beyond 15 months, the 10403 regimen was associated with a slightly higher relapse rate, which makes some sense since patients who are treated with an allogeneic transplant do generally have relatively good relapse-free survival if they can overcome the obstacles of the transplant. However, the conclusions of this paper were that the 10403 was overall superior to allotransplant in newly diagnosed patients with Ph-negative B and T ALL. However, again, a cautionary note, further refinements by detection of minimal residual disease in complete remission, disease genetics were not included in this analysis and need to be evaluated because there is likely a potential benefit of transplant in first complete remission in selected subsets of patients with ALL. And what I'm referring to really here is the sensitivity of the disease to the treatments that we give, reflected by presence or absence of residual disease at levels below the level of morphology or standard cytogenetics, what we call minimal or measurable residual disease. And you could see here on this slide that when patients who were on the 10403 trial achieved complete remission detected by minimal residual disease absence, that is, no detectable MRD after induction therapy, their 3-year disease-free survival is simply outstanding, as you can see here, compared to those who still had MRD positivity. And this was using a quantitative PCR technique, which is sensitive to about 10 to the -5th in most cases. And what's important, though, to mention here is that while these disease-free survival rates in MRD negative patients were superlative, only 40% of our patients achieve MRD negativity this early in treatment. And so it's quite different biologically, as we've known for a long time, than pediatric leukemias, where the majority of children are MRD undetectable after induction therapy. So some of our goals for the future involve deciding which patients should maybe get an allogeneic transplant in first complete remission, but I think more importantly, looking at how we can get more patients into that very outstanding curve where early MRD negativity is achieved. And the way that we're trying to do that is moving immune targeting into frontline therapy for patients with B-ALL. One of the things that has already been shown to improve outcome in a very nice prospective randomized trial in terms of immune targeting is the addition of rituximab to frontline chemotherapy in patients with BALL that are CD20 positive. This was a French study published a number of years ago, which shows that Rituxan in CD20 positive ALL improved event-free survival in a prospective randomized trial. Most of these patients did undergo allogeneic transplant in first complete remission. Nevertheless, this trial suggests that the addition of rituximab further reduced minimal residual disease burden, allowed more patients to have truly complete remissions, and had better outcomes. Unfortunately, only about 20 to 30% of patients with precursor BALL, unlike mature BALL or lymphomas, express CD20. So we've been in search for a more widely available antibody. And we have a number of approaches now in relapse refractory ALL in adults that potentially allow this kind of targeting. And they're shown here on this slide. All of these agents have recently been approved in the frontline setting, in the relapse setting for patients with acute lymphoblastic leukemia. We have blinatumomab, which is the CD19, CD3 bispecific T-cell engager. We have inotuzumab ozogamicin, a CD22 antibody drug conjugate, and most recently now in the United States, as of November 2021, we have approved CAR T-cell therapy for adults with ALL, previously only limited to patients under the age of 25, but with this new product, which is from the result of this ZUMA-3 trial, we now have approval for use of all of these agents in the relapse setting for patients with acute lymphoblastic leukemia. And a number of years ago, as we were thinking about how to have a better rituximab for our patients with ALL in the B lineage ALL, we decided to explore the two drugs on the left. The one that we chose in our younger adult population is inotuzumab ozogamicin. And that agent is now being studied in the frontline in a randomized phase 3 trial for adults up to the age of 40. The same population that we studied in 10403 are now being evaluated to see whether inotuzumab added to frontline therapy for patients with newly diagnosed CD22 positive precursor BALL makes a difference by reducing MRD burden and improving event-free and overall survival. And you can see here the schema of this trial. It's exactly the same as the previous with some minor tweaks to the steroid, the asparaginase dosing, and also the addition in both arms of this randomized study of rituximab in post-remission therapy if patients express, if the lymphoblasts express CD20 greater than 20%. And the patients are randomized to receive or not receive inotuzumab for 2 cycles immediately following remission, with the idea that early eradication of minimal residual disease will prevent emergence of resistant clones. Here again, in more detail, is the schema for the trial. We have some stratifications by age, although that didn't make a difference in this 18 to 40-year-old population in 10403. We are evaluating for this pH-like signature, which I'll come to in a minute, and by CD20 status, which we found, interestingly, in 10403 not to make any difference in prognosis, CD20 versus CD20 positive versus negative, which is different than some other studies, maybe because the treatment was good and overcame some of these previous resistance mechanisms. And so the patients, as I mentioned, undergo a standard induction, are randomized to receive either 2 cycles of inotuzumab or no inotuzumab. Then they go on to get consolidation with Rituxan if they're CD20 positive. After consolidation therapy, if there's still detectable MRD measured by this clone-specific PCR technique, the patients can then go off of study, not off of study. They can go off study. They're advised to receive blinatumomab, which we know has been approved for treatment of MRD positive CD19 positive BALLs. And if they're MRD negative after blina, they can then go either on to getting 10403, continuing on the treatment as outlined in the protocol that I just showed you, or they can be selected to have an allogeneic transplant, since typically in the United States now, patients who are MRD positive after consolidation are considered at highest risk for relapse and may benefit from an allotransplant. That is not a question that's actually being addressed in this A041501 trial. The trial is well accrued. I saw yesterday some updates to the accrual numbers, and 278 out of a total of 340 patients have been accrued. So we suspect that the trial will be hopefully fully accrued by end of next year. What about these patients with PH-like or BCR-ABL-like ALL? Well, they have a very similar gene expression profile to patients who are BCR-ABL positive, but they lack the BCR-ABL fusion protein. And this subset was described by using gene expression profiling. And the PH-like subset was associated with very poor clinical outcomes. The reason that it's very similar to BCR-ABL fusion protein in terms of its gene expression profile is that these patients have an activated kinase signature. Various kinases are upregulated as a result of usually small deletions, which result in fusions of that activate a variety of different kinases. And you can see that in the original studies, these patients with this activated kinase signature have a very poor outcome compared to others with ALL. This is from pediatric trials. So you can see the very, very good outcomes for patients without the PH-like signature. This is the subset that we're talking about. Similar data have been shown in the adult population where PH-like ALL have worse outcomes. We have shown that those patients are much more likely to have higher levels of MRD at the end of induction. And we can also show that the outcomes, as shown here on these survival curves, are worse for the patients with the PH-like signature. We believe and we hope, and we're going to get a signal for this from the trial I just described to you, that targeted antibodies for patients with PH-like ALL may be equally effective for that subset as it is for other patients with BALL, agnostic of what's going on inside the cytoplasm, as long as the lymphoblasts express CD22 or CD19. PH-like cases actually are usually strongly CD19 and CD22 positive. And this is just a series of small studies looking at the outcome of antibody use in patients with relapse refractory PH-like ALL. And these are all post hoc analysis, no prospective data yet, but suggesting that these patients with relapse refractory disease can have equally good CR rates with these targeted antibodies compared to, in comparison to patients without the signature, very similar outcomes. So you could see here some studies that looked at INO in combination with chemo, INO as a single agent, and blina as a single agent with good CR rates in patients with PH-like ALL. And we'll hope to get an answer, a bit of an answer from this, about this in our ongoing study where the PH-like patients are stratified in our randomization. How about patients with TALL? Is there an optimal regimen for them? We don't yet have targeted antibodies or CAR T cells for TALL, although there are some trials ongoing for CAR T cell mediated TALL targeting. Again, my screen seems to have frozen. Let's see. There we go. I want to show here that in the 10403 regimen, historically, our B and our TALL patients do equally well, regardless of immunophenotype. And I had mentioned earlier that age was not an important stratification factor in terms of outcome. There were no significant statistical differences in patients by age or by immunophenotype. So the patients with TALL did equally well as the patients with BALL, but we were challenged in the sense that we don't have, as I just mentioned, an inotuzumab or a blinatumomab type drug at this moment for TALL. Interestingly, daratumumab is being explored as a possible antibody, as well as the CAR-Ts that I've mentioned that are very early in clinical trials. But one of the things that was done a number of years ago was that in TALL, we do have a drug that's approved in the relapse setting, Nelarabine, which is a guanine nucleoside analog, and it is approved in relapsed ALL and with relapsed TALL, and it has been shown to now, in a very beautifully done 4-arm randomized study by the COG, improve outcome when it's incorporated into frontline therapy for patients with TALL up to the age of 30 years. This is a pediatric study, and here you see the survival curves, outstandingly good for both both overall and event-free survival. Nelarabine was incorporated in this study into a BFM type backbone, very similar to the 10403 that I just showed you, with 6 5-day courses of Nelarabine scattered throughout treatment, starting early, just right after induction therapy. Only a small percentage of these patients were between 20 and 30 years of age. So we don't have a lot of data on our young adult population here, but the 4-year disease-free survival was 88.9% with Nelarabine versus 83 without Nelarabine. The 0434 study, as I mentioned, was a 4-arm comparison. And I just will direct your attention to arm B, which is exactly the backbone that we use in 10403 and in the ongoing A041501 regimen with Capezi methotrexate as the interim maintenance, which is escalated doses of methotrexate with asparaginase. That's the backbone of Capezi. And when Nelarabine was added to this subset, to this regimen, this is where the outcomes were the absolute best. And really, when analyzed, the improvement in disease-free survival was really because of a reduction in CNS relapses, and that's what made the difference here. In terms of patients with lymphoblastic lymphoma, the study was really not powered to answer the question. But since CNS relapses are very rare in T lymphoblastic lymphoma, it's somewhat questionable whether Nelarabine will really significantly improve already outstandingly good outcomes for these patients, at least in the pediatric setting. So what are we doing to try to optimize these pediatric regimens for older adults with ALL? Well, one of the problems that we've learned is that these regimens are difficult. An intensive pediatric regimen cannot usually be faithfully delivered to adults over the age of 45 to 55 years old. And you can see here from a French study that these outcomes were shown, poor outcomes for our older adults with B and T ALL who were randomized to an intensive pediatric regimen. And those patients who were 55 or older did very poorly due to treatment-related toxicities compared to other patients who received this intensive pediatric approach. And you could see even in the slightly older population, up to the age of 50, 55, they also did slightly worse, but a dramatically worse outcome due to toxicity and inability to deliver the regimen. And even in our youngest adult population, we see subtle differences in toxicity even within our young adult population. And this was just published by my colleague, Anjali Advani, recently, where we looked at toxicity differences even in our younger adults with ALL and compared them to patients who were treated on the same regimen who were younger. And you can see that the patients who had a median age of 19 on our regimen, the patients who were randomized in the pediatric trial who were young adults had a slightly lower median age, 19, compared to our young adult trial, where the median age was 24. And even this subtle difference in age resulted in very significant differences in treatment-related toxicity. Just going to say that patients who, as we age, even in those young adult years, toxicities begin to increase, and in all organs, liver enzymes, increasing neutropenia, increased hyperglycemia, increased pancreatitis, all of these things, even in our youngest adults. So these pediatric regimens are hard and have to do likely with both obesity and other pharmacogenetic things, our ability to tolerate these drugs as we age. In a multivariable analysis, just to show you something about obesity, which is a huge problem here in the United States, impacting outcome, one of the only factors in a multivariable analysis of 10403, in addition to disease biology, the pH-like signature, which is shown here in this two, these were the only things really that were in multivariate analysis important in terms of determining outcome. There we go. And here we go. Patients who were morbidly obese had extraordinarily poor outcomes. And as this problem increases with age as well, we have to consider the impact now of obesity, particularly in the United States, where the majority of our patients on 10403 were in this age rate, were quite obese. And the morbidly obese, which accounted for about 8% of patients, did very, very poorly. One of the questions that we have to get to regarding that is potentially, because I showed you that the toxicities are greater in our older adults, and particularly potentially in our obese patients, are we overdosing pegylated asparaginase in our young adult patients? And does that limit our ability to deliver it to older adults? In a pilot study that we did at our center, where patients who had a median age of 46 years old, we decided to try to reduce the dose of asparaginase. In pediatric regimens in the United States, the dose is quite high, 2750 units per meter squared. But we decided we were going to go to this 1,000 unit per meter squared dose and see if we achieve therapeutic levels of asparaginase in this patient population, and to see whether that reduced treatment-related toxicity. And what we showed was when we gave this dose and even lower doses for patients who were morbidly obese, older, and with baseline liver abnormalities or diabetes, 81% achieved therapeutic levels with the lower dose. Actually, 100% of patients who had received 1,000 units per meter squared achieved a therapeutic asparaginase level. And overall, we did indeed find a decreased grade 3/4 liver and thrombotic toxicity. And this just shows, again, what I just stated, that 100% of the patients who had received 1,000 units per meter squared achieved therapeutic level. We did, in some patients, really reduce the dose. And what we did in these patients is if they didn't achieve a therapeutic level and they had no significant toxicity, we redosed asparaginase around day 14 of induction. We now have looked at the survival of these patients. These are older adults. The median age, as I showed you, is in the late 40s. And with that, the 3-year overall and event-free survival is actually is actually quite encouraging compared to our historical controls of our older adults. So adjusting the dose of pegylated asparaginase is one potential way to allow delivery of these pediatric intensive regimens in a safer way and potentially improve outcomes by doing it compared to our historical controls. Then the NOPFO study, a Nordic study that was recently published, shows again that the use of 1,000 units per meter squared using a very intensive pediatric regimen results in exceptionally good outcomes for patients even up to the age of 45 years. And so here in this regimen, again, 1,000 units per meter squared, which is quite common in Europe. And I'll be curious to hear what you use in India as your asparaginase dosing and how you approach the situation. But in Europe, in both pediatrics and often in adult studies, the dose of asparaginase is not as high as we've used traditionally in pediatrics in the United States. One of the other ways that we're thinking about trying to reduce toxicity from asparaginase is to use prophylaxis to try to decrease the hepatic toxicity, which is quite profound in the majority of patients, especially during induction therapy. And so this trial was just approved by the National Cancer Institute. The trial is now being written. The proposal was just approved this week. And this is going to be a joint study, including the pediatric and all of the adult cooperative groups in the US for patients up to the age of 40 years. And what's going to be done, and this is again, a prophylaxis study that regardless of the asparaginase preparation that is being delivered, patients will receive or not in a randomized fashion the addition of L-carnitine to try to reduce hepatic toxicity, because there are a number of small prospective studies suggesting that the use of carnitine will reduce hepatic toxicity, especially during induction therapy when it's the most profound. So both reducing the dose and potentially using prophylaxis may allow better use and more effective use of asparaginase, even in our older patients. But what else can we do in our older adults? And what we're hoping to do is to be bold and use less intensive chemotherapy, but use our new agents instead to hopefully increase response rates, decrease MRD, and decrease toxicities, thus resulting in improved event-free survival. I want to show you this sobering curve which was historical from the previous decades of treatment in ALL. And the yellow box here are our older adults with ALL. And you can see pretty poor outcomes for them, only 12% long-term survival for patients over the age of 60. So what have we been doing? This is a beautiful study that was done by the MD Anderson group, moving away from chemotherapy by incorporating inotuzumab ozogamicin, the CD22 engager, with this low-dose chemotherapy in the front line. In this study, there were 52 patients. The median age was 68 years, and extraordinarily high CR rates, high achievement of MRD negativity by flow, and excellent progression-free survival at 2 years, with good follow-up now, showing a plateau on that survival curve. So not as good yet as our younger adults, but compared to that 12% event-free survival, extremely encouraging. This is a single center study, and we're about to embark on a similar study in a randomized fashion in our adult NCT and cooperative groups in the United States to see whether this approach can become a new standard upon which to build. Again, having trouble advancing my slides. Let's see how I can do it. There we go. This is another approach, even less chemotherapy, where immune targeting as primary therapy was used almost to the exclusion of any chemotherapy. This is a study led by Anjali Advani in the Southwest Oncology Group. It was just accepted for publication in the Journal of Clinical Oncology, so you'll be seeing it soon. This regimen included blinatumomab, the CD19 BiTE, plus dexamethasone as initial therapy for ALL. No standard chemotherapy other than the dexamethasone and intrathecal therapy. The patients then went on to receive 3 additional cycles of blinatumomab with IT chemo, no more steroid, and then 18 months of a standard pump maintenance. The eligibility were patients 65 years or older, truly an older adult population. The median age was 75 years, as you can see here. And virtually all patients had intermediate or poor risk disease by cytogenetics. Importantly, no deaths were observed during the first 28 days of treatment. It was well tolerated. There was only 1 grade 3 neurotoxicity, which is something we worry about with blinatumomab, but wasn't seen. And the CR rate was quite good, 66%. And of those patients, 12 of 13 were MRD negative after the blina cycles. Here's the 3-year survival, 37%, not as good as what was shown with the INO mini CVD, but this is a national study. And this one had really almost no chemotherapy. So just an interesting beginning, I would say, upon which we can build, where patients were able to tolerate this treatment very, very well and have improved compared to our historical control of 12%, improved survival. This regimen was also adopted in patients with Ph positive ALL by addition of a kinase inhibitor, dasatinib, and outcomes are similar, although they haven't yet been fully reported. Another very interesting study, and I think this one is particularly interesting in that it can apply to both B and T-ALL, is something that is being explored quite actively in the United States at the moment, and probably elsewhere in the world as well. This is a study, again, using minimal chemotherapy with a mini hyper-CVAD regimen, but the addition, instead of a targeted antibody, the addition of venetoclax, the BCL2 targeting BH3 mimetic. In this study, patients with ALL, older adults, were given a mini hyper CVD regimen with venetoclax, and followed that. They got 4 cycles of that and followed by POMP maintenance with venetoclax. In this study, the median age, again, older patients in general, 65 years was the median age. It was a higher risk population. Some of these patients had very poor risk cytogenetics. There were ETP ALLs, there were P53 mutant ALLs, and some of these patients were also included in this regimen, in this protocol, were relapsed patients who didn't fare quite as well, but did quite well. I'm showing you now the data for the previously untreated patients. There were no protocol-defined dose-limiting toxicities and no deaths during treatment. And with that, you can see here that in the untreated patient population, which we're going to focus on, the response rate was 91%. All of them essentially were MRD negative by flow, and the duration of response still very early, but looking quite good. This is very, very early on. In the relapse refractory population, the response rate wasn't quite as good, but still not terrible for patients with relapse refractory B or T ALL, allowing some of these patients to go on to transplant. So another very interesting minimal toxicity regimen, combining a novel agent, venetoclax, allowing both B and T. Oops, I have to go back. Actually, it's fine. I don't need to go back. But this is a study, another one where minimal chemotherapy, in this case, no chemotherapy other than inotuzumab is being used. And this is from the German group, Dr. Stellis and colleagues. And this was presented at ASH a year ago, and again, an update this year, where 3 cycles of inotuzumab alone, no chemotherapy, just IT chemo, was given to patients over age 55 years. And what I'm going to show you here is some of the early data from this study. The primary objective is to use inotuzumab as induction therapy. Chemotherapy is added in later, and estimating the number of patients who are alive and well at 1 year. This is the regimen, as I showed you. It involves induction with inotuzumab alone, some IT chemotherapy, some conventional chemotherapy is then given, and then maintenance therapy. So it's not a chemotherapy-free regimen, but it starts as a chemotherapy-free regimen. Here are the response rates. 100% of patients achieved complete remission. Virtually all of them received 3 cycles of inotuzumab. Importantly, again, no induction mortality and high MRD negativity rates. A couple of these patients did go on to an allogeneic transplant, but the majority did not. And these are the early results of this trial showing overall and event-free survival. So all of these studies are showing that a chemo-free regimen or a chemo-reduced regimen can result in very, very high response rates and possibly good event-free and overall survival. The most radical of these approaches has been the AO41703 regimen, which is now fully accrued, where truly no chemotherapy in the standard sense is given. Inotuzumab is given for 2 cycles with IT chemotherapy. Blinatumomab is given for 4 cycles with IT chemotherapy, and there is no maintenance therapy. This trial is being led by Matt Wiedewoldt in the Alliance, and we hope to have results to present at ASH this year. So what is our future for our older adults with ALL? Our thought in the United States and the NCTN is that maybe we're going to be moving to a chemo-free regimen. And our hope is to eventually have a randomized study using inotuzumab, mini CVD, with the results that I showed you, as our new quote unquote control potentially. And then an arm where venetoclax, allowing T-ALL patients to be treated, is used, and then a totally chemo-free regimen potentially. This is sort of how we hope to see ALL in our older adults in the not too distant future. Just to show you a little bit about Ph positive ALL, which I haven't really had a chance to talk about this morning yet. This is an amazingly exciting result from the Italian group, combining, again, literally a fairly chemo-free regimen with CD19 BiTE chemotherapy. In this regimen, steroids, dasatinib, and blinatumomab were used for all adults with Ph positive ALL as frontline treatment. And the primary endpoint of this study, which has been published in the New England Journal about a year and a half, almost 2 years ago now, complete remission, complete molecular remission. There were 63 patients, a generally older adult population, which is true of patients with Ph positive ALL in general. You could see the schema here. Corticosteroids and dasatinib were used as an early induction, and then patients went on to receive blinatumomab, continuing dasatinib. The primary endpoint was after 2 cycles of blinatumomab, and with that, you can see here that at the primary endpoint, which was at day 85, the complete molecular remission rate was about 30%, but after 2 cycles of blinatumomab, I said day 85, this is when patients started the blinatumomab here. And then after 2 cycles, the complete molecular response rate went up to 60%, which was the primary endpoint, and continued, as you can see, to improve with even subsequent cycles of blinatumomab. Here's the overall and disease-free survival, truly exceptional for a disease where there was almost uniform mortality 20 years ago, unless patients underwent allogeneic transplant. And while a number of these patients did undergo allogeneic transplant, that wasn't necessary for maybe the majority of these patients. We don't know that yet. So again, my slide with the schema may incorporate our Ph positive patients, especially our older adults, by using one of these regimens plus a TKI in the frontline setting where we really don't have to use much chemotherapy at all. This is where we're thinking right now in the NCTN cooperative groups in the adults. So in conclusion, I'd like to say that adoption of pediatric regimens in young adults with ALL has improved survival rates, but toxicity does limit the expansion into older adult populations. And while we can use modified regimens to improve outcome, we hope that with the arrival of these new targeted antibodies for frontline therapy, that we won't need to use as much chemotherapy, and we will be able to improve event-free and overall survival by eradicating resistant disease early on, achieving minimal toxicities. As I mentioned just parenthetically, the addition of daratumumab is one such approach for MRD targeting in patients with TALL, and we can talk about that a bit in the discussion. We're hoping to minimize and eliminate chemotherapy altogether in our older adults by using targeted agents, either the kinase inhibitors, venetoclax, or the antibodies in frontline therapy for these older adults, as I've shown you some exciting new directions that are being explored. Is the future of ALL therapeutics chemotherapy free? Well, this time, for the first time, I think perhaps our insights from our older adults will inform the trials for our younger adults as we try to move away from the toxicity of these very intensive regimens. And with that, I would like to thank you all for being here with me. And I will be very happy to answer any questions. I'd also like to acknowledge my colleagues at the University of Chicago who are listed here. I work with a number of wonderful people without whom I could not do any of this work, and my colleagues in the NCTN and pediatric groups in the United States, with whom I've had the pleasure of working for many decades now, and with whom I do the correlative science studies. So thank you very, very much for your attention. Happy to answer any questions.
Thank you so much, Dr. Wendy. That was beautifully covered. You updated us with all the research taking place in this field, with all the data, and we are indeed grateful to you. A lot of hand-raised signs are there, but I'm going to take the opportunity of asking you one or two questions from the audience. I'll just summarize them and ask you. A lot of questions are related to whether you risk stratify your patients upfront and execute different kind of induction therapy to different ALLs.
That is a really good question. I mean, at the moment, what we're doing is, of course, because our frontline protocols are so focused on the addition of the antibody treatments, we are designing separate trials for the TALL patients. So in that sense, we do stratify. But in terms of other risk, in the randomized studies, the patients are being risk stratified by age, by pH-like signature, which is being done at a central laboratory using a low-density array card, and by CD20 status for our younger adult population. But other than that, we don't have any risk stratification currently built into our frontline trials.
Right. The other set of questions asked by many are, so what are your present indications of doing allo transplant in CR1?
Yeah, that's a hot question, and it's a hard one. I'm curious to hear what all of you do. But my current approach is that while I showed you the outcomes for patients with MRD negativity at the end of induction, which are exceptionally good if you have MRD negativity then, and I would not transplant those patients. The point in treatment when I use a BFM or intensive pediatric regimen, the point in treatment where I tend to think about transplant is if there is residual disease after consolidation, after the third block of chemotherapy around day 100. And if there's MRD positivity still present, that suggests to me relatively more resistant disease. And if patients are transplant candidates, I will often think about giving them blinatumomab, which, as we know, has been approved for treatment of MRD positivity if they have B-ALL, that's CD19 positive, and then apply allogeneic transplant as the next approach. but I don't routinely transplant patients anymore. And I showed you the data, not really randomized, the comparative data from the bone marrow transplant registry and 1043. So otherwise, I don't tend to transplant patients. Regarding pH positive ALL, that's the one I have even the hardest time with. And it depends very much. In my younger patients, I often still will take them to an allogeneic transplant, but increasingly, I'm not transplanting patients with pH positive ALL if they are MRD negative. On the other hand, we don't know that we can ever discontinue the kinase inhibitors in those patients. And there are long-term toxicities of those agents and the possibility of emergent resistant disease. So very interested to hear your approaches. I want to hear from you guys what you are doing.
Right. So one question you asked during your talk about the dose of PEG ASPA that we use. Yes, of late we have also dropped it to 1,000 per meter square. So toxicity here has been tremendous. A lot of Indians are sort of pre-diabetic. We have very, very high incidence of diabetes and complications related to sugars going up, lipids going up, the liver problem, thrombosis, and even losing patient with pancreatitis was left and right when we used higher doses. So yes, we have dropped it. And we are a bit more liberal with upfront transplant because we do not have an easy access to all the immunotherapies. Inotuzumab is available with us officially. Blina is to be obtained patient to patient, and CAR-T is still as a part of research. So we have little limitations on those fronts, and even the finance can be a limitation. So sometimes that upfront transplant becomes the cheapest modality of treatment than these agents. So with that, let us ask questions to our faculty. Dipankar, your question.
So thank you, ma'am, for this excellent talk. My question is, like I have a child, like she's 14 years of age, and she's pH negative BALL, and she presented with hyperleukocytosis, and she did not have any high-risk cytogenetics at presentation. So I started on BFM protocol, and like after induction as well as after consolidation, she had MRD positivity. So like more than 0.05%. So the issue is like what to do next, because she is on BFM protocol right now. So the three options which I was thinking, like first is to augmented BFM, or go with the inotuzumab or blinatumomab. So ma'am, what would be your choice in this case?
I think that this patient, this is a high risk patient for whatever reason, like you said, maybe has a pH-like signature, which you can't, is not easily identified. But I think in this patient is a B-ALL, correct?
Yes.
Yeah. So I think what I would do if I had all of the options in the world, this is a patient where the MRD is still high, and this is a patient I would take to transplant, but I would try to use blinatumomab if I had it to eradicate MRD prior to transplant. We know that lower level or undetectable MRD is probably best, and you often wonder whether those patients actually need transplant, but that would be what I would try to do. Now, if inotuzumab, as you were just saying, Dr. Agarwal, is available in India, I often have used inotuzumab, and actually my two of our residents at the University of Chicago are just putting together our final presentation, hopefully a manuscript, on looking at the use of inotuzumab as a bridge to transplant and the safety of it, and whether if you can get away with just one cycle of inotuzumab without and achieve MRD negativity, which is very possible, and use careful prophylaxis with ursodiol potentially throughout, I would then use that as a bridge to getting this patient to a transplant and then transplanting her. My goal there is to try to wait at least 4 weeks between the last exposure of INO to the beginning of the preparative regimen because of the risk of VOD. But in our series, importantly, what I wanted to say was that we had a series that we did also with Stanford University, and we have very low rates of VOD with INO as a bridge to transplant if it's applied carefully and without too many cycles.
Thank you.
Thank you, Dipankar. Take one more question from the audience. Do you still give different duration of maintenance therapy to females and males? That is,
You guys are asking the best questions, I have to say. I personally think we should not be doing that. I think we give too much maintenance therapy based on the rest of the world. We're locked into that in this current trial because we're trying to replicate or compare to the 10403 results. But I have to say that, and we did that based on following the pediatric children's oncology group regimens here in the United States, who do that 3-year from interim maintenance for boys and only 2 years for girls in the children's oncology group. Interestingly, for the very first time, the children's oncology group in standard risk patients is going to be looking at just that 2-year time point rather than 3. And as you know, and as all of you know, most of the regimens in Europe and probably in India as well only have 2 years. Do you just use 2 years of maintenance therapy?
it's 2 years.
Yeah. I mean, I think that makes sense. I don't know that there's any data that really suggests that they need that extra time. And it is extra toxicity.
Thank you. Sharath, your question.
Yeah, Dr. Wendy, thank you for a lovely overview on ALL. Now, just to continue on the transplant talk, I mean, our Indian data for ALL and CR2 outcomes are really dismal in the 15 to 20% range. So like Dr. Agarwal mentioned, our best bet is upfront, where we try to identify a subset where we think probably post-induction or like you mentioned, post-consolidation MRD positivity is the subset we would consider taking, especially the ones who are below 50, because that's their best chance. And then try and get them MRD negative pre-transplant because the outcomes are clearly different when you're negative versus positive. So that's the general thought process. I mean, there are other of my faculties who can kind of still talk on that issue. My question here is, we are kind of moving into the CAR T cell therapy era. It's kind of available in the US for sure. Centers are coming up in the country here. Where would you place CAR T versus the allo in the subset where you really want to give a curative intent treatment?
Yeah, that's an outstanding question. And I don't think I have a good answer for you. My own approach right now, well, the data were just published from the ZUMA-3 trial, which are the adults with the CAR T cell therapy. It looks like some of those responses are durable. I have to tell you that we enrolled patients in that trial. I have a number of patients who are on that trial, and I took the only ones who are still alive and in remission are those patients who went on to an allogeneic transplant after getting the CAR T, which was a wonderful way of getting very resistant disease into a remission, but a huge resource. I mean, so expensive and so toxic to the patients with relapse disease. Now, perhaps in the minimal residual disease setting, it will not be that bad. Now, saying that, my approach right now is if a patient gets CAR T cell therapy, I have been taking them forward to an allogeneic transplant. Whether that's necessary or not, time will tell. Interestingly, some of the new CAR T products seem to have longer, quote unquote, durability without T cell exhaustion. There are some that are being developed now, and maybe those will be more persistent, and maybe if applied in the MRD setting, can truly eradicate disease and then obviate the need for an allogeneic transplant. But at this moment, I have been using CAR T therapy, which I haven't had the opportunity to use very often, actually, because it was just now approved in the United States. I've been taking those patients to a transplant after.
Right. Thank you. Thank you so much.
Thank you, Sharath. One more question from the audience. Dr. Shyam Rathi has put a case, young Ph positive, CD20 positive, ALL. Will you add rituximab? Will you give L-asparaginase, considering the toxicity of giving them with dasatinib?
Both good questions. I think the addition of rituximab, if it is CD20 positive, I think that there are good data to support the use, even in the Ph positive patients who, interestingly, usually do not express CD20 or often do not. So yes, in terms of whether they need additional chemotherapy in addition to steroid, I don't know. So the answer for me is recently, our studies have not involved combination chemotherapy with the TKIs. They've been, especially during induction, just steroid plus TKI to get patients into a good remission. And then you can think about adding in low-dose chemotherapy or taking them onto a transplant. But I think from the data that I just presented from the Italians, you could see that a good TKI, and now people are adding ponatinib in the front line with just blinatumomab, and that study is ongoing in Europe and at the MD Anderson in the United States, that you may not need any intensive chemotherapy. And I agree that asparaginase in combination with a TKI might be difficult. And I have not traditionally used that.
Thank you. Prashant?
Yeah, very good morning, ma'am. I have two questions, both are pretty basic. One is that previously, before PEG asparaginase came into existence, we used to avoid vincristine and L-asparaginase given together to avoid the drug toxicity. So when we are giving PEG asparaginase, now do you advocate dose reduction in vincristine dose?
No, we don't. We don't give a reduction in the vincristine dose. We still give, a cap of 2 milligrams of vincristine, and we give. In fact, the drugs are often given not exactly on the same day, often, but within a day or two of each other. So, for example, there are days where they get vincristine and asparaginase on the same day. We have not found a problem with that necessarily. Although it's it's something I actually haven't really previously thought of, because our regimens often have that. During induction, I have to say the vincristine is usually given on day 1 and the asparaginase usually on day 4. So there's a spread there during induction. And as you know, some centers now, and I think it's quite an interesting idea, wait to give the asparaginase until the second week of treatment, when all of the DIC and inflammatory stuff has resolved, and making it more likely that the patients will tolerate the asparaginase. I think that's a very good idea. It's not something that we've done routinely in our frontline trials, but I think it's a very good idea.
Yeah, ma'am. Thank you. And one more question. A lot of our patients upfront, when they present, they have severe thrombocytopenia, less than 10,000 platelets. And sometimes during treatment, they develop a lot of coagulopathies. And in a kind of a economically constrained situation, it becomes difficult to administer required number of intrathecal chemotherapies to these patients. So in that kind of patients, do you advocate an increased number of intrathecals during maintenance, or an low-dose whole brain RT even in B-cell ALLs?
I think that's an interesting question. I mean, what we usually do is we do try to give platelet transfusions so that we can get the intrathecal therapy delivered early on. But I think that, occasionally if an LP is missed, it should be made up. I don't know that if the CNS is negative for involvement at the time of diagnosis, I don't think from much of the data that exists now that radiation therapy is needed. And even in TALL now, the St. Jude group for years has not done any kind of radiation therapy for those patients. Of course, there are very intensive regimens. But to get back to your question, I would just try to make up the dose. I would try very hard not to wait too long to give that IT chemo, but I would make up the dose at some point.
Thank you, ma'am.
Thank you, Prashant. Another question from audience is about T lymphoblastic lymphoma with a mediastinal mass. Do you follow up with the mediastinal mass also, doing a PET scan, and if it is positive, biopsies, etc.?
I think we're kindred spirits, all of us, because I have the exact same questions and I don't know the answer. Recently, I have been doing that. I have been doing a PET scan There are very few data on that, as you know, in lymphoblastic lymphoma. I have been doing it. I've been following it. And so far, I've been lucky, because what would I do if it was very positive still? I would be very worried. And I think then that would bring up, a question about treatment resistance and what to do next, whether we would go to an allo, whether we would radiate that. So I have been following as a marker, but I don't know exactly how I would act on it. Unfortunately, so far in these patients who tend to be relatively chemo resistant, although when they relapse, it's a terrible problem, as we all know. And I'm hoping that this might be a way of detecting potentially resistant disease that I need to alter the treatment.
Thank you.
Dr. Agrawal, can I just add on to that, sir?
Please go ahead.
Yeah, so we did have a study when at Tata Memorial. We did a study on prognosticating the negative PET scan status after induction therapy in mediastinal T-lymphoblastic lymphomas, and we presented it as a poster at ASH, I think in 2017 or 18, and then we have recently published the paper. In terms of prognostication, patients who were negative completely at the end of the day did far better in terms of their event-free survival and long-term outcomes in these patients. We had a 5-year follow-up on these patients, and it's a small study, but that was the data that we had.
That's really interesting. I mean, are you doing that now in lymphoblastic lymphoma, T-lymphoblastic lymphoma as well?
After that, as part of an institutional protocol, yes, we were doing it. And we have published that in that data in, I can't remember in which journal, but we have published that. I think in 2020 we published that data. It's on a small group of patients.
I think it's useful. I think that's useful information, because there's not much information out there. So I would love it. I should look at the paper. Because
yeah.
I
will, if you share the email, I will send you the paper. Yes,
I will be happy to.
Yes.
Dr. Agrawal can share my email with you. Because I don't really know what to do. I have a young man who's just finishing now his 2 years of maintenance therapy, which in this case, lymphoblastic lymphoma is one case where the COG has decreased the length of maintenance therapy. His PET has been negative, but and he'll have a final one next month. But I was like, what will I do? I mean, I would be horrified if it was positive, but then what? But so I have been following, but I don't know exactly how to act on it. And just to know that it's prognostically relevant is important too.
Yeah.
Thank you. Dipanjan.
Thank you, Dr. Wendy, for the wonderful talk. My question is regarding ETP ALL. So how do you approach like giving induction therapy to these patients? Do you use a different kind of regimen? And once they fail the conventional regimen, where do you what is your salvage approach? Like, do you use stronger chemo, use daratumumab? What is your approach for these patients?
That is another great question. So for the ETP ALLs, we use the standard approaches. Some of them are very chemosensitive, interestingly. It's a quite heterogeneous group in my limited, experience with these patients. But we use standard therapies and we measure MRD. You may remember, and this has not yet been published, that a couple of years ago at ASH, the Children's Oncology Group, Brentwood, presented data from that trial that I showed you, the nelarabine trial, on patients with ETP ALL, showing that they were slower to clear MRD, but that if they were MRD negative by flow at that day 100, they had as good an outcome as other patients on that regimen as the precursor TALL. Now, what happens when they're resistant? That is a great question. And one of the things that we're going to be exploring in the United States is the addition of daratumumab. So if patients, both ETP and T, are MRD positive after consolidation, we are going to have a small pilot trial that should begin hopefully later this summer, adding daratumumab to see whether it can eradicate MRD. The other agents in which I'm particularly interested and with which I've had some experience are the BH3 mimetics. And what we found in a relapse study that was published just about 6 months ago now in Cancer Discovery. Oh, it's actually almost a year ago now in Cancer Discovery. We did a phase 1 study of venetoclax and navitoclax, which is BCLXL, which may not be that important actually in ETP-ALL, at least up front. Venetoclax is very important. And we found high response rates when those two agents were combined with low-dose chemotherapy in patients with both relapse B and T ALL, including ETP-ALL. So one of the other ideas that we're going to explore in the front line now for all patients with TALL in the NCTN group is the addition of the BH3 mimetics to frontline therapy. I think that one of the studies that I showed you on the slide was that one with the mini hyper CVAD with venetoclax, and there were ETP-ALL patients on that study. They responded very well. These were frontline study, but even in the relapse, there were response rates. So that would be another thing that I would think about for those patients if they've already been exposed to nelarabine, especially.
Thank you. Dr. Aishwarya, your question.
Thank you, ma'am, for your wonderful update. So as you mentioned that on flow, our cutoff of 20% is required for rituximab in cases of CD20 positive ALLs. So what is the cutoff for CD22 on flow so that inotuzumab can be given? Like, can we give it? It's less than 20.
Yeah, that's another really excellent question. First, to get back to the rituximab, that's what we used in our study. But people at the MD Anderson feel that any level of CD20 expression is acceptable for use of rituximab. In terms of CD22, there's been a paper published from the initial inotuzumab study, the INNOVATE trial, looking at the level of expression that's needed for efficacy of inotuzumab. And while most patients express high levels, it doesn't seem to matter that much. There may be some off-target effect, so that if a smaller percentage of the population is CD22 positive, it still may be effective, maybe not quite as effective, but in up front anyway, frontline therapy, most patients express very, very high levels of CD22. So is there a cut point? Probably not, although we don't have really good data on how well the very low level expressors do. Just parenthetically, I have a patient just now who is, and this is again, just a total anecdote, but this patient has only a 40% CD22 expression on his lymphoblast. He has relapsed lymphoid blast crisis of CML. It's a terrible problem, this patient's disease. It keeps coming back. But amazingly, he responded very nicely to inotuzumab with only 40, CD19 negative this particular case, but CD22 about 40% with a good response. So I think it shows, just in my own experience and from the data, which doesn't clarify about really low levels, that lower level expression can still, inotuzumab may still be effective.
Thank you, ma'am. And pertaining to pH positive adult ALLs, so like most of the studies, they propose that TKI prednisolone steroid combination has been like quite bringing them into remission and all. So I wanted to know,
You got muted.
how frequently and at what time points of therapy should we be monitoring the pH clone so that we can modify the TKI dose and
Yeah, you know, my approach has been to do it monthly. I monitor these patients every month. It's easy to do for my center, so I'm very lucky about that. And probably that's the case. You have such good technology as well. You could probably monitor. I check it every month. Do I act if there's a subtle change? No. If there's a subtle change, I don't. But if there's a trend, you know, 2 to 3 months in a row of going up, then I think, oh, is there a 315I clone emerging or something like that? And then I will do sequencing to see whether I can start to detect that. Although sequencing, as probably you already know, and maybe you have more sensitive technology, but there probably has to be at least 5 to 10% of the population that has that mutation before you can detect it by the techniques that are typically used in our diagnostic labs in the US.
Thank you.
Thank you, Aishwarya. A couple of audience colleagues are asking about how do you choose between inotuzumab and blinatumomab?
Yeah, that's another really fun question to think about. I think in the MRD setting, you know, blinatumomab is approved. Inotuzumab is not, but I have used it in that setting as well, especially if patients don't express CD19, which we sometimes see actually, vice versa. Sometimes patients express CD19, not CD22. But for the relapse setting, I tend to favor inotuzumab for patients with bulk disease because it has a higher response rate overall. And so for patients with bulk disease in the relapse setting, I tend to use inotuzumab. If the patients have significant liver pathology, then for sure I would not, because there is the risk of VOD. But for MRD, I have been using blinatumomab. That's where it's approved, and it's extraordinarily effective. And otherwise, I tend to use INO as my first choice for bulk relapse disease.
Thank you. Dr. Nityanand?
Yeah. Okay. That was a very, very nice talk and very informative, you know, and a lot of concepts have got cleared. I just wanted to ask you that in the data that you showed from your center, where you talked about the sequencing of the immunotherapy, you showed that with the principle that in adult ALL, you want to get them into an MRD negativity. So if after induction, you showed that you'd given INO, and then you went on and gave consolidation, you know. So because we are a resource constrained country, so my question was that if after giving induction, if the MRD is positive, then if you give INO versus if you just give it upfront as you've shown in your data, have you kind of looked at that?
No, but it's a very good point. I mean, it's sort of, you're getting to it's a very good point. You know, should we be tossing this at everybody, you know, because it is expensive. It's no question, it's an expensive drug. So that's a very good question that hasn't really been addressed yet, but we will be able to look at that, you know. I mean, we won't be able to really ferret out, you know, who responded well or who didn't, but in terms of, you know, did the MRD positive patients really need it? You know, that's what the MRD negative patients, do they really need it? That's what you're saying. And I don't know the answer to that. Our study won't really show that. It will be able to evaluate because we will have an MRD endpoint and an MRD measurement at the end of induction. And so we'll see if there is a difference in MRD clearance in the MRD positive versus the negative, but it won't answer your question. But your question is an excellent one in terms of trying to conserve resources. Is this a really essential thing? And the answer is maybe it isn't, because we know that the 85% disease-free survival for the MRD negative patients from 10403, they did exceptionally well. So they probably won't get that much more bang for the buck from inotuzumab. So I think that would be a way of sort of thinking about it. We know that those patients did exceptionally well without INO. Maybe they'll do a little better, maybe we'll be greater than 90%, you know, but when you're up in that range, all of us in the world of adult ALL, the pediatricians wouldn't be satisfied yet. And of course, all of us want every patient to survive, but the risk, you know, the cost benefit ratio may not be there for those patients. And same is true for Blina. You know, do they really need Blina? And actually, just to get final point about that is that there was a huge study that was done by the Eastern Cooperative Oncology Group, an NCTN-wide effort, looking at Blina. And it was going on at the time that Blina was approved for MRD, before it was approved for MRD positivity. And so at the end of the trial, there are going to be patients where we're going to see whether Blina actually impacted the MRD negative patients. So we'll know that. So we'll get some additional information to get to your question. to answer your question.
One more question, this is in relation to CAR T-cell therapy, that one of the main problems is the relapses, which I believe with bispecific CAR T-cells, it has been reduced to some extent. But what is your view on how further the relapses can be reduced? It's an expensive therapy, So how further we can reduce the relapse rates after CAR T cells?
Yeah, so that's I think the technology is evolving so quickly. So like you said, the bispecific or dual targeting CARs may be better, but there are some other really interesting strategies that I think are being explored. One of which, where there's already some data. The one that I find very, very interesting is this CAR T that has been designed to have lower affinity, lower avidity. So it has a fast on, fast off effect. It doesn't bind for long. It doesn't cause huge proliferation of the T cells. And it's a British study. The product is, I think it's called Autolus. And the idea is that by having the fast on, fast off, the lower affinity, lower avidity product, you will not get as bad CRS, but most importantly, potentially, you'll have durability because the T cells won't get exhausted. And the results from that trial, which are very early still, look like there is good durability of the T cells and long responses. So maybe that will be a way of overcoming. In the other patients right now, as I said, I have been taking my patients to transplant. Potentially, you could use some alternative therapy to maintain MRD negativity, but anything that we do in the world of ALL tends to be lympholytic. And so if you have the hope that you have some residual CAR T cells, you're going to knock them out. But most people believe that they're gone pretty quickly, and it's just a matter of how well you've done right off the bat, I think. And maybe these longer duration CAR T cells will change the equation a little bit.
Thank you. Thank you very much.
Thank you.
Thank you. Coming back to the audience, there are many questions about rituximab because that's cheap and easily available. How many number of total doses of rituximab do you give to a patient?
Yeah, so in our protocol currently, let me think. I think there are 5 doses of Rituxan that are given. We don't give it during induction, in part to avoid tumor lysis, but more so out of an economic thing. In the US, most of our patients are in the hospital during induction therapy for ALL. And in the US, there's a weird financial constraint on the use of rituximab in the hospital. So we're not allowed to deliver the drug during inpatient stays, except for emergently. And so we designed the trial to give Rituxan starting during consolidation therapy. So we give, actually, I misspoke. We give 2 doses during consolidation, we give 8 doses total of Rituximab. We give 2 during consolidation, each of the modules of consolidation, during interim maintenance, and during delayed intensification, 2, 2, 2, 2.
Another question related.
Now, I should say, I'm sorry, I was going to say that in the GRAL trial that was published in the New England Journal, they gave a huge number of doses of rituximab. I think they gave like 16 doses. So I don't know that that helped or hurt, but that's what they did. But we decided that wasn't feasible economically and or maybe necessary.
Right. The question about rituximab is whether it can be given with blina and INO.
Yeah, that's a good question. I don't know the answer. I don't see why not. Maybe we'll have triple therapy, all antibody mediated, like INO plus Rituxan followed by blina plus Rituxan or something like that. Who knows? I wouldn't see a problem. I don't know that you would want to be doing them all on this exact same day, but of course, blina is a continuous infusion right now. I don't see the problem of giving once you've gotten over. You have to be careful with Blina at the beginning because there are CRS events that can occur, especially in the relapse setting. So you wouldn't want to be bombarding them with both drugs on the same day, I think, when you first start.
Right.
But I
Another
don't
question
see a
about
problem.
immunotherapy is between Blina and I know if there is a CNS disease, is there a preference?
Neither is the preference, unfortunately. The only thing that probably crosses the CNS are those CAR T cells. And there are studies that are ongoing. Certainly it's been used for CNS lymphomas now. Interesting, there was just a paper published that I actually highlighted that I wanted to read. I saw it, I think it was just last week, that said that there were no increased incidents of CNS toxicity in patient. Oh, I know what it is now. It's from Stanford. The last author is Leora Schultz. It's published in Blood. I think it was just last week that they looked at the CAR T cells in patients with extramedullary leukemia, and they found that there was no increased CNS toxicity in patients with CNS involvement with ALL who got CAR T cells, which is very encouraging. Now, did it help or not? I don't know. But that would be my hope, because CNS relapse in ALL is such a tough thing, especially in the Ph positive patients, where I see it quite frequently in the patients where I don't transplant them, and even sometimes in the transplanted patients.
Dr. Verma, your question.
Thank you, ma'am, for your nice presentation. So in your presentation, you mentioned that obesity is one of the major risk factor, like age and others. So how do you explain, like, what is the pathophysiology behind this, being obesity one of the such a big risk factor for poor outcome?
It's a really good question. I find it really fascinating. I think there are multiple things that probably are at play, including there is some very, very interesting data on the adipocytes functioning sort of as a like a little protective nest for lymphoblasts, that it creates a protective niche in the marrow, that a lot of adipocytes. That's one thing. There's probably some very fascinating monocyte biology around adipocytes as well, sort of immune deregulation from obesity that is being explored. I find this all really, really, really interesting. In addition, we know that metabolism of some of our drugs is very much changed when people are obese, and we may be just overdosing some of our drugs because we're going by body surface area. And that's how I feel about asparaginase in particular. I just wonder if sometimes we're giving these extraordinarily high doses just because of body weight, where the area of distribution of the drug is the same, and we're just overdosing these people and putting strain on the antioxidant system and the detoxifying mechanisms in the body. So there are some SNPs that have been associated with both impaired metabolism. Not that directly relates to obesity, but maybe that's another issue that some of these obese patients have, and it may account for their obesity, have differences in certain SNPs for metabolism that result in impaired clearance of some of these drugs. But I think some of it has to do with protecting the marrow niche, and some of it has to do with impaired metabolism and increased toxicity. Because in our trial, you saw these patients dropping really quickly. It didn't really have to do necessarily with treatment resistance in our trial, because once they got out of the initial weeks of therapy, if they were survivors, some of the obese patients, there was a plateau on that survival curve. So I think a lot of the early toxicity has to do with drug metabolism issues.
Thank you, ma'am. One more question, ma'am. So for patients with Ph negative ALL more than 50 or 55 years of age, would you recommend other dose reductions or removing some of the drugs in induction if we are using BFM95 protocol?
Yeah, Yeah, I think that, we talked a little bit about it before. What we've done, we've done the dose reduction in the asparaginase, which I think is the most important. Maybe moving the asparaginase to day 14 is a good idea. The other thing that we have occasionally done, although I don't know if I'm a big fan of this, is we have reduced the way that we give the steroids are days 1 through 8 and 15 through 21. That's how we and in our older patients, we omit that second pulse occasionally. So that may also reduce toxicity. But I think the main toxicities of the regimen have to do with asparaginase and steroid combination. And so anything you can do to minimize that is probably the best. And I think 1,000 per meter squared, as I showed you, achieves therapeutic levels. So, and then maybe if you even pushed it out during induction to day 15 or day 14, it would be easier.
Thank you. Thank you.
Dr. Hari? You're muted, Hari.
So my question is on T lymphoblastic leukemia. We know that they have a lot more delay in clearance after induction. So, and we know that MRD is relevant over here too. So my first question is, where do we place the detection of the MRD in T-ALL? And suppose we have a scenario, we do multiple MRD levels and we see a declining trend in the MRD and eventually they become negative. And in these patients, would you consider, because it's a high risk, would you still consider doing a transplant in these patients? Or because they have become MRD negative over a period of time, you would still consider just continuing with the standard chemotherapy in these patients?
Yeah, I think about that a lot. I think this is a very important question that I struggle with a lot. In terms of when the best time point, I think from the German data, the best time point for all patients with ALL in terms of deciding about transplant or not is at the end of consolidation. If you're using a BFM type regimen. So that's usually around, after 3 intensive treatment months or so. The Germans say weeks 12 to 16 of treatment. I mentioned earlier in my talk, just parenthetically, that these data have not yet been published, but that Brentwood presented a plenary session showing exactly what you said, that the T-ALL, particularly ETP-ALL, clears more slowly. And so you shouldn't be so fretful about the end of induction MRD, especially in the ETP-ALL. But again, by day 100, if those patients cleared, they were better. Now, you make a very important point, I think, which I've also seen, that some of these patients clear even more slowly. They're going down, but they're not gone. It's still detectable at the end of induction. And I have, even in my younger adult patients, in those particularly about whom I'm very worried about taking to transplant for psychosocial reasons. A lot of my patients are from the center where I work. There is a lot of poverty. There is a lot of underserved resources in those patient populations, making transplant a really risky proposition. And it's hard enough to get them through ALL therapy, much less a transplant. And so in those patients, I too have occasionally, if the trend is continuing down, I have bucked the tradition of saying, okay, I'm taking this guy to transplant right now. If it's steadily coming down, I have watched. And as long as it's steadily continuing to come down and I can monitor it every month, and we use now this next gen sequencing technique, the clonoSEQ technique, where we send it off to a lab, and it's a company in Seattle. And we can do it in the blood. It's quite reliable. It's not perfect, but we can monitor the MRD monthly. And as long as it's still coming down in these high risk patients where I'm very worried about taking them to transplant, I do not transplant. And whether or not that's a good idea or not, I don't know. It's still early, but I have to say that I have not seen relapses in those patients yet. And this is all in the last couple of years. So it's early business, and it's anecdotal data from my own personal experience. But I totally agree with you that there are these patients who come down, especially the T-ALLs, very, very slowly. And it's not until the end of delayed intensification sometimes when they're MRD negative. And I think if they achieve that, I think hopefully they'll be okay, but I just don't know yet.
And can I have another question? It's on lymphatic leukemia. I mean, in B-ALL per se. We know that most of our patients do not undergo transplants, irrespective of whatever the MRD or whatever it is, but they become negative. And would there be a role for, and many of the relapses occur in late maintenance in these patients. So it was just something that crossed my mind. Is there any thought on that about using any of these monoclonal antibodies sometime in maintenance therapy to just get rid of those clones which may be missed during the treatment, because we don't routinely do MRD studies during maintenance?
Yeah, no, I think that's a really interesting idea. And I think that will be, I was even thinking that potentially in the future, and this is not right now, and is that maybe that's the moment to use the CAR T cell, is when and then just be done. Not go on for 2 years of maintenance. But I do think that there might be a role for these antibodies during maintenance therapy. It's just hard to know, because if you're MRD, again, it goes back to the question that was asked earlier. If you're MRD negative, do you actually benefit from getting these, or is it necessary? But it is an interesting idea. One of my fellows and I actually have written a protocol that we're doing in pH positive ALL, where we don't stop the TKI, but where we've written in to give inotuzumab during maintenance therapy, a couple of doses. A couple of exposures rather. So I don't know that we're going to get an answer, but we have the same idea that maybe it's a good idea to try to get at really low level disease later on, because that's when the patient, and I think by better MRD monitoring, maybe we'll get a handle on that, and then can apply, as just was asked earlier, is that the moment to apply that agent? Because they are costly. It's not something we could just randomly start tossing out to people. But I do think that as we get better and better at monitoring MRD in the blood, so that patients don't have to have marrows every month, we will be able to trend this out and figure it out much more readily.
Thank you. Thank you.
Thank you. Again, going to audience, there's a question about ruxolitinib for PH like ALL. Your comments.
Yeah, we have a study. We haven't, this is so frustrating. There are some published papers. There are some published data on that from the pediatric world, and from Sarah Tajian and colleagues at the Children's Hospital of Philadelphia. And it does look like that ruxolitinib can be useful. It may not be the be all and end all. We also have a trial for PH like ALL with CRLF2 or JAK pathway activated PH like ALL. And we haven't yet accrued anybody to the trial, but I think there are some data suggesting that it's A, feasible, that has been shown in pediatrics, and B, the efficacy part is not yet known. But the results that Sarah had presented a couple years ago at ASH were encouraging, and I know the trial is ongoing, and we also have a trial in our adult population that we hope to accrue to. I think there are better agents probably coming forward. I don't think inhibition, but maybe in the MRD setting, it will be a good idea for these PH like ALLs.
Thank you. Dipankar.
So ma'am, the next question is, I have a 50-year-old PH like ALL with CRLF2 mutations. So I had started on BFM protocol because he was his performance status was good. So he was tolerating the BFM protocol fine, and after induction, so his MRD was negative, and post consolidation also he had a negative MRD. So ma'am, what to do further, to continue the BFM protocol without opting for a allogenic transplant, or we should get away with a transplant? That would be a better option.
Yeah. Another outstanding question, and something that I struggle with too. I think that, I'm nervous from the data that was presented from MD Anderson, that the quote unquote MRD negative patients with PH like ALL still do poorly. And I was influenced by that. So I had been taking many of those patients, even just like the person that you recommended, to a transplant. But I'm beginning to wonder about that. And I have not necessarily taken every one of those patients to an allo, especially because now I feel like I've got some, if they're an outstanding candidate for an allo and you have a good social support system and a good donor, et cetera, I would still think about it just based on the data that exists, that these patients may still have resistant disease below the level of detection of the MRD assays. But I think with our better MRD assays that are now 10 to the 6th, 10 to the 7th, and the ability to monitor them closely, I wouldn't necessarily take that patient to a transplant. Also because, as I was just about to say, there are reasonable salvage options for these patients with INO or Blina or maybe even CAR T. So it is a moving target. A few years ago, I took all of those patients to transplant, and I have a few of them, and fortunately, they're doing fine. But I also have a few who are now finished with maintenance therapy who haven't relapsed, who were early MRD negative. And so I think this is still something that remains to be looked at. And I know in the children's oncology group that if you're MRD negative, regardless of your pH-like status, you are not transplanted.
So can I ask another question?
Sure.
Yeah. So ma'am, what CNS directed therapy should be given in like a pH negative B-ALL with a CNS3 status, like triple intrathecals versus like a high dose methotrexate versus a cranial RT. So what should be the preference like in a CNS3 status?
When they present like that?
Yeah, at diagnosis.
If they present with CNS3 status, the approach I used to do it differently, but I now try to follow faithfully what the pediatricians do, which is they just give they give weekly chemotherapy, intrathecal therapy during induction, and then continue that during consolidation. Therapy, and those patients usually clear quickly. Those are the patients, though, who do get cranial irradiation at the end of delayed intensification. If they present with CNS3 disease, they still get radiated, although not right up front. And no, I don't switch to a high-dose methotrexate containing regimen. I just follow the protocol, which is a few more IT chemos during induction, and then do cranial prophylactic, low-dose cranial prophylactic radiation at the end of DI.
So ma'am, any number of intrathecals which we should limit, because I have seen some patients with myelopathy in the maintenance who are given intrathecals. So should we limit our intrathecal if we are giving high dose methotrexate maybe during the consolidation phase? So should we limit our
yeah, I think that's an important, I think the CNS issues, the CNS toxicities of our chemotherapies and radiation are understudied. And I think that's an area I think about all the time, because I've seen the same thing. I've seen these terrible myelopathies, maybe demyelinating disease from patients who are potentially overtreated. But I think in the frontline setting, the number of IT chemos that are given in the frontline setting in the US and the COG, and now in our young adult protocol, are 17. They get it all throughout maintenance therapy. The COG does use high-dose methotrexate during interim maintenance. We do not. We use the Capizzi escalated methotrexate, but regardless, they get 17 IT chemos, and we haven't seen a lot of toxicity with that. It's, they get cytarabine only once, and it's traditionally a triple therapy. It's traditionally just methotrexate. There was a randomized study from COG comparing the two, triple versus methotrexate, and there was no difference in the end. Actually, interestingly, the triple therapies has less systemic relapse, but not less CNS relapse.
Thank you, ma'am.
Thank you, Dr. Afak.
Thank you, ma'am. Thank you for an excellent talk.
Thank you.
I agree with you that ALL has been a success story for pediatric patients with a cure rate of 80 to 90% with chemo protocols. We have applied the same pediatric inspired protocols in AYA patients, and they have done reasonably good with cure rates of around 70%. but the story is not good for adult ALL, say age 40, 50 years above. And we have been using chemo protocols for decades together and with dismal results in adult protocols. As you have rightly pointed out, that we need to combine the biological agents upfront with the chemo protocols. But till we have access to these agents, what is your suggestion to us that we improve our outcomes? We have protocols like BFM, UKLL protocol, or other protocols, but they are all chemo based, and they don't tolerate well these aggressive protocols. They are not fit for transplant. What to do with older elders, say 50, 60 ALL first time? What should we do?
Yeah, I mean, I think these are challenges, because I think the best one could do is to reduce the intensity of those pediatric regimens if you don't have the agents to switch, if you don't have anything novel to add, which I understand. And that was one of the reasons I wanted to present the data on our older adults where we treated patients up to the age of 70 with that pediatric regimen with the modifications that I showed you, and that is published now by my colleague Anand Patel. It's not as good. It's not 70%, but it's better than 12%. So I think the ways to move forward at the moment for our older adults is to use as good a supportive care as we can, and to modify those regimens that are already in play in our older adults. And maybe you do have access to rituximab, maybe adding those to the front line in those particular patients will help. And maybe if you have access, and this is something that has not yet been studied wholeheartedly, is for the TALL patients, perhaps using nelarabine in the front line at the doses that have been approved for older adults, which is a little different than the schedule that's used in pediatrics, which, for the relapse patients. So those are the things that I would think about for, areas that are under-resourced in terms of the new agents. My hope is that, as, for example, I don't know, maybe venetoclax will become available to you in a more,
it is available.
Yeah, so I think that mini hyper CVD venetoclax regimen is truly fantastic. It's early, I can't say, but 100% response rate is nothing to sneeze at. And so, I think that those kind of regimens with these drugs that are coming forward, the antibodies clearly, venetoclax is as expensive as inotuzumab, but maybe more accessible. And maybe if we could use that just even for a month or two early on to really reduce disease burden, we'll do better. So I think the older adult world, we will have to, if we want to make major strides, we can't use these pediatric regimens faithfully. And we just have to figure out ways to do better. But I think we can modify them and do somewhat better. And then maybe use some of these new agents as they come forward.
Thank you, ma'am. Thank you.
Dr. Rajni.
Ma'am, that was a wonderful talk. So my question is is it mandatory to get an MRD negative status before proceeding for transplantation, especially in pH negative ALL patients? So even after 3 blocks of intensive chemotherapy, if the patient is still MRD positive, do you want to intensify your chemotherapy further, or can we proceed for transplant?
Yeah, that's another really good question. I thought I had a slide. I had so much trouble advancing my slides. I might have skipped right over the slide, but there is a paper that was published. I thought I had it in my talk. I actually thought I put it in there yesterday when I was putting this together, from the French group. The first author is Dhedin, Dhedin. They looked at the impact of MRD on transplant. And basically what they found, it was quite an interesting study to me. They found that patients who had MRD, who were MRD negative, actually didn't probably benefit from a transplant, i.e. didn't need it. But patients with low level MRD, who went into the transplant with low level MRD, did benefit. It's not as good, of course, as being MRD negative, but you can pummel a person with so much chemotherapy, you're not going to get there. And maybe if you do that, if they're low level MRD and they go to transplant, maybe they won't need additional therapy after, or you can monitor them. And if there's MRD, maybe add some maintenance therapy. I mean, that's of course a bad situation, but the data from that study did show that low-level MRD patients did benefit. They didn't do quite as well as those who were MRD negative, but they did do much better than if they weren't transplanted.
Okay, thank you, ma'am. So other question, like, do you routinely do gene expression profiling or the NGS tests in all your patients?
No, we don't do
to identify this PH like ALL subset of patients.
Yeah, that's what we do. Well, we have started to send samples for RNA sequencing, but we don't do that yet routinely. There are, and then you would pick up the PH. But what we do to try to identify these patients is two things. We first do flow, because you can identify CRLF2 very easily with flow. So our lab does flow on all of our new ALL patients. And of course, in adults, at least in US, the adults tend to have more of the JAK CRLF2 mutated subset of PH like ALL. We also have a FISH panel that our cytogeneticists have designed with the common fusions, like the ABL fusion, PDGFR, CRLF2, and JAK fusions. So we use those two things. In our clinical trials, we have this low density array card that's done. It's not commercially available. And that pretty faithfully identifies the PH-like signature, but it won't tell you which fusion is present. So you'll just know, yes, they have PH-like ALL or not. But that is not a commercially available. In our own center, as I said, we do flow and this FISH panel.
Thank you, ma'am.
Thank you.
Sure.
Satish.
Thank you, sir. Thank you, ma'am, for an excellent talk and also for patiently answering all our questions. Most of the doubts have been cleared. Thank you so much. I just wanted to confirm about the role of cranial RT. You mentioned in your talk in CALGB protocol, you are giving cranial RT after intensification for all the patients of TALL?
Oh, so what? No, we give it to very few patients, but if they present with CNS3 disease, that's when they get it. They've already cleared their disease, of course, but to prevent relapse, that's traditionally how the Children's Oncology Group in the United States has done it. Until just this current generation of trial, all patients with TALL, regardless of CNS status, got cranial irradiation at the end of DI as well, but only the CNS3 patients got cranial prophylaxis with BALL. And I try to avoid it whenever possible, but those are the patients where I would give it still at the end of delayed intensification, because CNS relapse is dreadful.
So for all TALL, you would recommend cranial RT?
That is the hard one. And the pediatricians are moving away from that. So standard risk TALL, no, they're not doing it anymore. In our clinical trial that we're currently doing, we are not going to, that we're designing, we're not going to do it, but we haven't tested that yet.
And in lymphoblastic lymphoma, if PET is negative, but if there is, some enlargement, mediastinal enlargement, do we give mediastinal RT?
I do not.
Okay. Other thing is in patients who require transplant, allogenic transplant, is it TBI conditioning, or are you moving away from TBI conditioning?
Another good question. For the younger adults, I use a TBI-based regimen. Tend to use TBI-Cy, although we also have used TBI etoposide. I think the toxicities are intense. For our older adults, I use a fludarabine busulfan-based regimen.
Right. Thank you so much, ma'am, again.
Sure.
Thank you. Dr. Aniket Moite, you have put a lot of questions in the chat box you want to ask directly.
Yeah. Good morning, ma'am. Thank you for an excellent talk. I have a patient. She is a AYA. She was initially treated by a pediatrician, and she had a lot of complications during the treatment, the pancreatitis and thrombotic complications. So now she had 2-year DF disease-free interval and has relapsed. And because of the prior complications, she is a BALL with TEL AML. and has relapsed with 2 years DFI. I was planning and has a recurrence of with medullary as well as an extramedullary mass in the breast. So in such case, to give a combination of chemo along with immunotherapy, which of the immunotherapy would you consider?
Yeah, if you,
which would penetrate the breast also.
Yeah, in terms of extramedullary disease, there are some data emerging that on the targeted antibodies, and it appears potentially that inotuzumab may be better in that setting than Blina for extramedullary disease. I don't have a lot of personal experience, but the steroid alone might take care of that extramedullary breast disease. But I think I would go, if I could, with inotuzumab in this setting and then try to get this patient to an allogeneic transplant. It was BALL, correct?
It was BALL, and I'm planning for transplant for her, but I'm along with the chemo because she has prior history of all those things. She had required Rayleigh tube and TPN for a month to month and a half because of pancreatitis.
Yeah.
So I am trying to get her into a lesser chemo dose so that I can get her to transplant, at least survive the therapy. Right?
Yeah, I think inotuzumab, if you could get it, would be a great choice because you would avoid the pancreatic toxicity. You might target that extramedullary disease. Of course, every time I say give these agents, as we talked about earlier, neither penetrate the CNS, so you need to give IT chemotherapy when you're giving these new agents along with them.
Yeah, I mean, fortunately, she doesn't have a CNS collapse. She has a marrow and a non-CNS extramedullary.
Breast, yeah. I would give INO if I could. And if not, maybe you could do the CVD venetoclax if you have venetoclax there, because then you avoid the asparaginase, which was presumably this the major culprit here with the pancreatitis and thrombosis.
Yeah. Okay. Thank you. Thanks.
Darlene?
Yeah, that's a nice talk, and my majority of questions were answered, madam. So we have been seeing a lot of posterior reversible encephalopathy syndrome.
You got muted, Stalin.
With asparaginase, do you re-challenge with pegylated L-asparaginase in the next cycle if the patient had a press? And is there any minimum time duration so that next pegylated L-asparaginase need to be withheld until what time?
Well, I've never seen press with PEG asparaginase. That's something I haven't seen. So, but I don't know. So but in terms of, other toxicities, for example, liver toxicity from asparaginase, that's so common during induction. We do see that uniformly, essentially. And as long as the liver enzymes resolve, I will re-expose the patient to PEG. The only times I don't re-expose patients to pegylated asparaginase are pancreatitis, severe pancreatitis, and of course the anaphylaxis. And we now have, I don't know if it's available now in India as well. There's a new preparation of Erwinia asparaginase, which is much more reliable in terms of supply. It's called Rylase in the United States. And so you could substitute that in but in terms of when to re-expose patients to asparaginase, I would wait until the toxicities have clearly resolved. And as I said, I haven't seen press. I've certainly seen CNS toxicity in the sense that people feel awful. They sort of have a flat affect. They don't want to eat. But I haven't seen true press, I don't think. And I've never had a documented case, where the MRI findings were consistent with that.
Okay, ma'am. Thank you.
Two last questions related to transplants. One is related to how do you avoid infertility or reduce the incidence of infertility? The second question is post-transplant in CR1, is maintenance therapy mandatory?
Good questions. I mean, the fertility question is key especially for our young adults. We try to actually, any patient who's going to be considered for transplant, we actually discuss fertility issues right up front. Some people are far too sick to to undergo cryopreservation of ova. And, with standard chemotherapy approaches in ALL currently, neither women nor men, if they're younger, are likely to be rendered infertile. But prior to transplant, we try to do cryopreservation of all of our patients in order to have that option for the future. I forgot now the second question.
Second was maintenance therapy is required after.
Oh yeah, right. So that I do, because of this, again, one is so influenced by the experiences that you've had, right? So recently I've had a number of patients who've had isolated CNS relapse after allo. And and they've had quite a lot of prior IT chemo, but not as much as if they've gone through an entire regimen. So my standard approach right now, the only standard maintenance that I give after an allo is I give 3 to 5 IT chemos after an allo for ALL. And I usually start around day 60 and give once a month for 3 to 5. And whether that's right or wrong, I don't know. Otherwise, I don't tend to give any maintenance therapy. Now, having said that, there are some very fascinating things that I didn't have even time to talk about in the patients who are one of the subsets who are at truly highest risk for relapse, which are the MLL rearranged patients, all of whom I actually do take to transplant in first remission if I can get them there. That's the one subset, and hypodiploid, where I usually think about allotransplant in first remission. I didn't even talk about that. But in those patients, the MLL rearranged is a very fascinating drug that targets menin, which is essential for the transforming activity of MLL rearranged leukemias. And that drug is oral and is being tested in the relapse setting, not in post-transplant. But I have a feeling in the next few years that that drug may come forward. Oh, there are a couple of companies working on these menin inhibitors. They're fascinating. They do work in the relapse setting. We have a trial of such. And when you see an MLL rearranged patient who's relapsed respond to a single oral agent, it's nothing short of breathtaking. And so these agents can work. I don't know how they're going to come forward development-wise, but I think in that setting, if you had a good oral agent, maybe you would give them in the post-allo transplant setting for those really high-risk people. And like we were talking about earlier, what about the patient who went into transplant with MRD positivity? Could we do something like that afterwards to reduce the risk of relapse? I think all of those things are coming, and maybe coming pretty quickly.
Right. We have no more questions in the chat box and the question answer. Anything from here? Anyone? None? Then, ma'am, extremely grateful to you.
It was a pleasure. You have such an engaged audience. You ask the best questions, and I look forward to chatting with you by email about cases, because I have this exact same issues that you face. We are kindred spirits. So have a good evening.
Large audience from 14 countries to be
wow.
who have logged in. So therefore, so many questions. A lot of them are students doing their fellowship. So they are,
I'm very happy.
Exciting questions.
And it was a wonderful, you asked the best questions, all the things that I too ask myself every day when I see my patients with my colleagues. So take care, and hopefully they'll all do better. They'll continue to do better.
Have a great weekend.
Thank you so much. Bye.
Thank you, ma'am.
Bye.
Good night.
Thank you.
Everyone.